Good morning and good afternoon. Thank you for joining day 4 of our 2020 virtual user meeting, Cardiac Safety Testing from Ion Channels to Human Hearts. My name is Jason Villagomez, Marketing Manager at Nanion Technologies, and will be your moderator for today's presentations. By default, all participants are muted, and upon completion of the presentations, I will open up the floor to some questions. We encourage you to submit questions throughout the course of the presentation. It is now my pleasure to introduce Dr. Sonja Stoelzle-Feix, Director of Scientific Affairs, Nanion, Product Manager of the Cardiac Site 96 and Flex Site 96, and a member of the CiPA Ion Channel Working Group. She will be presenting ICH S7B Best Practices Considerations, New Questions and Answers. Immediately following this presentation, Dr. Alison Obergrussberger, Scientific Communications Manager, also of Nanion Technologies, will be presenting benchmarking best practices and calibration standards for HTS, high throughput screening, HERG recordings for improved proarrhythmic assessment. I'll now hand over the presentation to Sonja for the start of the talk.
Jason, thank you so much. And good morning and good afternoon, everyone. So for today, I'm happy to give you an update on the ICH S7B best practices considerations and the new Q&As. So the document was actually released in August this year. And good news is the ICH S7B Q&As have reached step 2 and are open for public comments, which means public can comment back to regulatory agencies now. And today I will bring you up to date on the best practices considerations for in vitro studies. So basically the goal of these Q&As is to provide a more robust and reproducible evaluation of potency of drug block of HERG current using patch clamp techniques and heterologous expression systems. So specifically, the idea is to provide a robust evaluation of IC50 values based upon the IC50 values and also the clinical Cmax values as it is contained in the S7B Q&A 1.2. Specific applications of the best practices for the HERG current could be clinically related to limited exposure ranges, large heart rate changes, lack of placebo group, inability to safely dose subjects, and the lack of positive control in clinical studies. Now, there are 7 areas touched upon in the Q&As, and I will highlight the key aspects on all of those. And the first one here within experimental conditions basically is recording temperature. So the HERG current kinetics is temperature dependent, and the potency of HERG block is temperature dependent for some drugs. And therefore it's recommended that patch clamp studies should be performed at near physiological temperature, so 35 to 37 degrees. The second topic is the experimental protocol. So the voltage protocol eliciting the HERG current should approximate elements of the ventricular action potential, so containing the repolarizing ramp or going for an action potential. The protocol should be applied as physiological rates, so 1 to 2 Hertz, to elicit frequency-dependent effects. And the input resistance is to be monitored to prove cell health and stability. And if a high C resistance is maintained, the holding current and RS can be used to reflect cell health and electrophysiologic stability. Any residual background current should be assessed with saturating concentrations of selective blocker, and if prominent, a leak subtraction can be done. So here, for example, you see the CiPA HERG protocol with the repolarizing ramp. This would be an exemplary current response. So the HERG with the maximum here in the ramp, this would be a block. And this is an example of monitoring of a parameter over time. Here, for example, of course, the current amplitude versus time. So the current in control, vehicle control, and full block in the end. Now, moving on to considerations with regards to recording quality. The seal resistance should be sufficient to minimize error due to leak conductance. The series resistance compensation should used to optimize voltage control should be noted. And stability of current recordings should be demonstrated with baseline recordings to characterize drug-independent changes, for example, rundown. The equilibration time course should be graphically illustrated to demonstrate steady state effects, and also cumulative drug exposure is possible when there are stable recording qualities and cell health given. Now, in terms of primary endpoints and data summary, here we are looking at defining an IC50 value for block presented as micromolar as well as microgram per milliliter, and also a Hill coefficient. So a justification of highest concentration tested and relation to therapeutic free and total drug levels should be provided if 50% block cannot be achieved. Any correction methods for current run-up or run-down used in IC50 estimation should be described. And with regards to recording quality, things should be documented in the data summary. For example, time course plots of current amplitude, input resistance, and the holding current. Now, the next topic is concentration verification. So here, both nominal and measured concentration should be reported. A validated analytical method should be applied to solution collected from the test chamber. So here, for example, from the Patchliner module, sample collection to a mass spectrometry analysis system. And the measured concentration should be used for IC50 determinations if values differ significantly. The assay sensitivity should be demonstrated using 2 or more concentrations of positive control spanning 20 to 80% block. The study may be inconclusive if positive control data fall outside the expected range of values. And vehicle that includes all non-compound materials in test solution, for example, solubilizing agents, preservatives, should be included as a negative control. Right, so to conclude this part here, here you see the original graphic from the S7B guideline. And now the new Q&As have different sections covering different parts. For example, the integrated risk assessment, the best practice considerations covering the core assays like PatchCamp, as I just showed in the previous slides, and Q&As, which cover the follow-up studies. So the in vitro best practices should provide harmonized approaches that reduce data variability, enable comparisons across labs, enhance translation to clinical findings, and guide regulatory considerations. Now, let's have a look at the ICH S7B core assay outcomes and the clinical risk. So the new Q&As describe multiple scenarios. For example, the double negative scenario or a non-double negative scenario like the intermediate scenario here. So double negative means that both in vitro HERG assay and in vivo QT assay are negative. In other words, within a double negative scenario, the risk is very low. So this would mean here you would have no reason to look at other channels besides HERG. But for example, if you have an intermediate, so a non-double negative scenario, then you could go for the other cardiac ion channels, so sodium, calcium, and so on, to support the interpretation of the clinical QT data. Right. So this is a slide that I've stolen from Hugo Vargas' SPS presentation. I liked it a lot. Best practices requires cross-industry teamwork. This was also his title for the very same slide. And what he also said is that CRO business is increasing a lot during the last time. And this is actually what we also noticed from Nanion over the last year. So basically, all of us together can really influence and have an impact on the global regulatory community. So from Nanion's side, being a platform provider, first of all, we are happy that most of the large CROs in the world are running one or multiple SyncroPatch systems already in their lab. This is nice for us. So for that system now, I made yet another conclusive slide here. So I'm going to briefly highlight the key aspects of the 7 areas that are being touched upon in the Q&As. So regarding the technical aspects, the SyncroPatch allows to do temperature control, giga-ohm CS are possible, cumulative drug additions are possible, and biosampling, so the collecting the samples is also being implemented at the moment. Regarding the software aspects, monitoring of the requested parameters is possible, RS compensation is there, and the correction methods, for example, for run up or run down, is also given. So this bit here I named teamwork with our customers. Maybe it's more like a knowledge transfer. So basically the knowledge that we gain from being an active member of the CiPA initiative almost right from the beginning is directly transferred to our customers. So we provide the adapted experimental protocols. The reporting of parameters is also adapted. And actually together with the FDA, we are working on the open data formatting to have your data directly transferred to the FDA in the perfect format. So yeah, basically with that, I would like to thank you guys for listening. And I would like to directly hand over to Ellie, who will present to you a little cross-site study that we from Nanion did together with two emerging CRO companies from Japan. This is Axelid and Novare, who are doing the CRO work for Daiichi Sankyo. So I think you can look forward to some really nice data now.
Okay, thank you, Sonja, and welcome everybody to this year's user meeting, which unfortunately can't take place here at Nanion, but is taking place virtually. I'm a little bit early, but I hope that's okay for everybody. Thanks very much, Sonja. That was a nice update. I'm going to look now a little bit more detail at using sort of benchmarking best practices for high throughput HERG recordings using automated patch clamp. And as Sonja mentioned, this has been a collaborative effort between us, Axelid and Navarre, or Daiichi Sankyo also. And we published the results earlier this year in the Journal of Pharmacological and Toxicological Methods. This is a summary of the topics that I'm going to cover today. I'm going to start off with a bit of an introduction into the automated patch clamp instruments that we use for this study, these being the Patchliner and the SyncroPatch. I'm then going to go through the main reason or reasons why we undertook this project to benchmark these best practices for HERG recordings. I will then go through the experimental factors that may or may not influence IC50 and finish off with some conclusions about best practices for HERG recordings using automated patch clamp and some future experiments that we have planned. So automated patch clamp has been used in cardiac safety testing for some years now, and in fact most if not all laboratories performing safety pharmacology are using automated patch clamp. I'm sure you're all aware of the comprehensive in vitro proarrhythmia assay, or the CiPA initiative, which Sonja gave a little bit of an update before. Since it started, in the CiPA initiative, Nanion has taken an active role in particular, but not limited to, the ion channel working group. And this group was set up to test a set of compounds deemed low, medium, and high risk on a number of different cardiac ion channels, including NAV 1.5 peak and late, CAV 1.2, KV 4.3, KCNQ1, KIR 2.1, as well as HERG. And the two instruments that we have used for recording the data used in the CiPA pilot study have been the Patchliner, shown here in the middle, and the SyncroPatch 384, shown here on the right. The Porter Patch is our smallest instrument for automated patch clamp recordings, but as this one did not take part in this study, I won't refer to this instrument anymore, and I will simply focus now on the Patchliner and the SyncroPatch. For those of you who don't know, the Patchliner is a fully automated robotic system for recording up to 8 cells simultaneously. With the Patchliner, you can expect good success rates in the order of 70 to 80% for getting a gigaseal, coupled with low cell usage. So this means that a low number of cells is required per well to get good success rates in the region of as low as 300 cells per well. And this is important when you're recording precious cells like iPSC cardiomyocytes or other primary cells. And features such as physiological temperature, which Sonja touched on earlier on, and I will come back to a little bit later in my talk, along with dynamic clamp and current clamp recordings, make it an ideal device for recording safety pharmacology experiments and for other applications. The SyncroPatch 384 is a fully automated high throughput screening instrument for recording up to 384 wells simultaneously for each module. You can expect also high success rates for getting a giga-ohm seal in the order of 70 to 80% with good access control and a good voltage control and stable recordings. And again, features coupled with features such as temperature control and current clamp make it an ideal instrument for safety pharmacology recordings and also other applications. So now I've introduced the instruments to you, I want to go through the reason why we decided to undertake this project of benchmarking best practices for HERG. Over the course of the CiPA initiative, a large cross-site and cross-platform study was undertaken. The Patchliner and the SyncroPatch took part in this, along with some other automated patch clamp instruments, which shall not be named, across multiple sites. So Nanion took part in this in our 3 sites, Germany, US, and Japan. And what we learned from this study is that when we compared the IC50s across the different instruments and the different sites, there was actually rather a large variability depending on the compound. So compounds such as dofetilide and terfenadine displayed a rather large variability. In the case of dofetilide, this was up to 10.4-fold, whereas other compounds such as quinidine displayed a lower variability in the order of 1.7-fold. And what we asked ourselves is, where does this variability come from? And can we come up with some guidelines for best practices to minimize this variability and record accurate IC50 values? So we thought of some experimental factors which we thought could influence IC50. And these are listed here. The voltage protocol, does the voltage protocol that you use, the step ramp protocol recommended by CiPA, or the step pulse protocol, which has been used as a standard HERG protocol in many labs, does this make a difference? The compound storage material, what you make your compounds up in, incubation time, number of replicates, and if you use a single point versus a cumulative regime, does this make a difference to the IC50? So I'll go through now each one of these in turn, starting with the voltage protocol. And the 2 voltage protocols we chose were this CiPA, or the step ramp protocol recommended by CiPA, shown here on the left, or a 2-second step pulse protocol, which is a standard HERG protocol, or standard for eliciting HERG in many labs. And what we wanted to find out first of all is, well, does the voltage protocol make any difference to the stability of the recordings? So to do this, we took our vehicle, which was 0.3% DMSO, and we applied this 4 times to the wells after about a 10-minute of control recordings. And I'm pleased to say that the recordings were very stable. There was no rundown over the course of the experiment, which lasted over 36 minutes, regardless of the voltage protocol used. We then took one of the CiPA compounds, verapamil, and we applied this in increasing concentrations to the wells, which were, the HERG current was elicited either using the step ramp protocol or the step pulse protocol, which we saw on the previous slide. And verapamil blocked the current regardless of the voltage protocol in a very similar way. And when we plotted the concentration response curve, we found that the IC50 was almost identical, so between 500 and 800 nanomolar. And then we plotted the IC50s from 27 of the CiPA compounds. The HERG elicited either using the 2-second step pulse protocol or the CiPA protocol, and we calculated the Pearson's correlation coefficient, and we found that the IC50s correlated extremely well with an R-squared of 0.99. So what we can conclude from this is whether both the CiPA step ramp protocol and the step pulse protocol are suitable for HERG recordings, and it does not influence IC50. Moving on now to the compound storage material. Both the Patchliner and the SyncroPatch 384 have flexible storage areas. So on the Patchliner here, you can see you can have your compounds made up in glass bottles of various sizes, Eppendorf tubes, which can be made of polypropylene or Teflon coated. You can have glass vials, and you can also have different well plates, for example, 96 well plates, etc. On the SyncroPatch, we also have a very flexible storage area. Here we can have different well plates, one well plates, multi-well plates, 384 well plates made of different materials, including polypropylene, Teflon coated or glass coated. And what we did here was we compared the IC50s obtained from compounds made up in glass coated wells versus compounds made up in polypropylene, 384 well plates. And we found here the correlation was also actually very good, with an R-squared of 0.998. And for 21 of the 27 compounds, there was a discrepancy of less than 2-fold, so about 1.8-fold. Just 6 compounds, which are highlighted here in red. These were astemazole, cisapride, domperidone, droperidol, pimozide, and terfenadine. They exhibited a discrepancy of 2.3 to 2.9-fold. So we asked, so where does this discrepancy come from? Why do these compounds display a higher discrepancy than the other ones? So we looked at 3 compounds in a bit more detail: astemazole, terfenadine, and verapamil. We had the compounds made up in different plates, either Teflon coated, polypropylene, or made of glass. And the results are shown in this table, which is color coded for so you can see it a bit more easily. And what we found was, depending on the storage material, so when the compound is made in Teflon coated or polypropylene plates, the longer the compound is in the plate, the higher the IC50. We can see this quite nicely with astemazole, where we see that in polypropylene or in Teflon coated plates, in any longer than 30 minutes, then the IC50 is increased more than 3-fold. The same trend is seen with terfenadine, but not with verapamil, which you might expect because verapamil is not such a sticky compound. On the other hand, if the compounds were made up in glass, this discrepancy was not seen. So we did not see this increase in IC50 even after 3 hours. So what we can conclude from this is that compounds should be used within 30 minutes of preparation if made up in polypropylene or Teflon coated plates. And if the experiment is going to last any longer, or if there is a longer gap between compound preparation and the start of the experiment, then the compounds should be made up in glass. Moving on now to incubation time. So this is the amount of time that the compound incubates with the cell. What we did with this experiment was we calculated the IC50 at different time points between 2 and 10 minutes. And what we found was with compounds such as verapamil and bepredil, shown here in the red and the green, was that after 5 minutes is enough time to reach the steady state and to reach maximum block. And the IC50 does not change much after that. But with compounds such as dofetilide, shown here in blue, or astemazole, shown here in black, then 5 minutes is not really enough time. So there is a large discrepancy with estamazole. If you calculate at the IC50 of 9 minutes of incubation versus 3 minutes incubation, you get a twofold change in the IC50. And with dofetilide, it's even more pronounced. So if you take the IC50 at 9 minutes, it's 4 times more potent, or 4 times lower than it was at 3 minutes. So what we conclude from this is 5 minutes is the absolute minimum that you should incubate your compounds, and actually for sticky compounds, longer is better, and maybe as much as 8 or 9 minutes is required for to reach the maximum block. Moving on now to the number of replicates. In a high throughput screening laboratory, the number of, to minimize the number of replicates and thereby increasing efficiency of the experiment is desirable. So the lowest number of replicates is what you want. However, based on success rate and variability of the data, an N of 1 may not be enough to rule out false positives and false negatives. Therefore, what we did here was try to find out what is the minimum number of replicates we need to do in order to get an N of 3 wells to take into our analysis. And what we've done here is averaged the IC50 values for an N of 4, 6, or 8 wells, or over the whole plate for verapamil using single-hole chips, and dofetilide using a 4-hole chip. And what we find when we plot the spread of the data is that there's actually, the spread of the data is actually very low. So even with an N equals 4, it is within twofold of the median. And what we can conclude from this is that with experiments with a high success rate of something like 90%, an N of 3 or 4 is probably enough to yield the N equals 3 that you need to take into your analysis. For experiments with a slightly lower success rate of something like 80%, shown here with verapamil, then an N of 6 may be required to ensure that 3 wells are good enough to take into the analysis, and thereby minimizing the variability of the IC50. And finally, single point versus cumulative addition. So when doing automated patch clamp experiments, you can either apply the compounds in a cumulative fashion, so from all concentrations on all of the wells, so from lowest concentration to highest concentration, which is shown here on the left. Or they can be a single addition of a compound or a single concentration to each well, and then the concentration response curve is calculated across multiple wells, and this is shown here on the right. The advantage of cumulative addition is that multiple data points can be gathered from each well, thus reducing the cost per data point. The disadvantage is, as we saw a couple of slides earlier, if you have to incubate your compounds or each concentration for at least 5 minutes, and you're doing a 4 or 5 point concentration response curve with some minutes of control also, these experiments can be in excess of 30 minutes. What we did in this experiment was to calculate the concentration response curve using a cumulative addition versus the concentration response curve that we got from a single point addition, and the concentration response curve then averaged across multiple wells. And what we find is actually the concentration response curves overlay almost exactly, and the IC50 is almost identical. So this we also saw for a number of other compounds, including astamazole, terfenadine, and verapamil. So what we can conclude from this is that either a single point addition or a cumulative addition can be used, and this does not affect IC50. The next slide just gives a summary of the best practices for HERG recordings using automated patch clamp. The things that I've touched on today are things like the replicate number should be n equals 4 to 6, depending on the success rate. The compound plate should be, it can be polypropylene if you use your compounds then immediately for experiments, but glass vials or glass coated plates are preferable. A minimum incubation time of 5 minutes should be used, and actually this may need to be extended with sticky or compounds that take a longer time to equilibrate or to reach steady state. Other recommendations we would make would be to use always negative and positive control on the plate, as well as always recording some control data at the beginning of each well, and using your negative control to measure and account for any non-test article artifacts such as pipetting artifacts. So now we've completed our benchmarking best practices for HERG. What are we going to do in the future? Well, we do intend to extend these best practices for other ion channels that are included in the CiPA initiative. For example, NAV 1.5, and these experiments and analysis are actually going on as we speak. We also intend to address some of the other issues that Sonja touched on earlier on, like the biosampling or taking the sample after the experiment. And for the last couple of slides, I just want to focus on these two factors of HERG recordings at physiological temperature, and also to bring in an idea of being able to extend your workday and your productivity with unattended runs. Now, at the time we did our experiments, we did them all at room temperature, but as is stated in the Q&A document, which is here, I just took the sentence or the couple of sentences that were relevant here. So some compounds do display temperature sensitivity. We have seen that ourselves. Some years ago, we were able to confirm that erythromycin is 10 times more potent when recorded at physiological temperature versus room temperature, which we did on the Patchliner. And as is stated in the Q&A document, it is impossible to predict at the moment which compounds will display temperature sensitivity or temperature dependency and which will not. So far on the Patchliner, we have recorded some of the CiPA compounds at physiological temperature and compared the IC50s at room temperature, and so far with compounds bepredil, cisapride, and E4031. These are not affected by temperature, so the IC50s are roughly the same. On the SyncroPatch, we have also done these measurements with a couple of compounds, quinidine and terfenadine, and we also find that here the IC50s are also similar at physiological temperature versus room temperature. So for my last slide, I just want to bring in this idea of unattended runs and being able to increase your throughput by letting your robot work a little bit longer. So in these experiments, we used NAV 1.5. We used a double pulse protocol so we could investigate state dependency. And we ran 7 compounds on the plate in duplicate. So for every well, we got 2 IC50s for, so one for the first peak and one for the second peak. And we had this duplicated on the plate. And what we can see here is a heat map of the recordings. This is all nice and blue. So this means that this is basically the negative control. This is the vehicle. And we can see that there's very little difference between most of the wells. Of course, these yellow ones here that stand out, these are our positive controls. So these are getting a full block concentration, so they are fully blocked. When we compare the IC50 values, so I should say that we did these experiments. I didn't do them myself. One of my colleagues did these experiments. So she basically loaded the MPC 384 plates into the SyncroPatch. She loaded the compounds and the cells, and then she let the robot run for 6 hours without further user interaction. So she recorded 10 plates in 6 hours, and with a success rate of, what is that, 95% or something. And then plotted the IC50s, and we also see excellent correlation between the IC50s that were recorded on the plate with an R² of around of 0.975. So what this means is there's also a very low false positive and false negative rate. So you can be very confident that you can load your plates and your compounds and your cells into your robot, and you can let your robot record more data whilst you go home and have a glass of wine or a beer or a coffee or whatever your tipple might be. And when you come back in the morning, you can have a complete data set and having improved or increased your throughput and your productivity, and you didn't have to do an all-nighter in the lab. So that just remains for me to thank my colleagues in Germany and Denmark and my co-authors on the paper, which were Nina, Nadine, Surin, Sonja, and also in Japan, Otsuki-san and Oka-san. And of course, our collaborators, in particular Takasuna-san and colleagues from Axelid and Doi-san from Navarre, and also our cell providers, SB Drug Discovery and BZIS. And thank you all for listening. So Sonja and I are happy to take any questions. Hold on a second, Jason, I need to, right now I can hear you.
Perfect. So I'll just go ahead and start from the top. Thank you for the presentation. Again, Ali and Sonja, that was wonderful. The initial question, Sonja, are these best practices written down only for manual patch clamp or also automated patch clamp? Or maybe you can comment on this a little bit more.
In the document, it specifically says manual and automated patch clamp. So it looks like the recommendations are generalizable. So it's for both methods.
And a follow-up to this, the best practices seem to highlight HERG. How about any other channels?
Yeah, that's a good question. Again, the description here is indeed, looks like it is for HERG. But again, when we look at the different scenarios that are outlined in the paper that I also mentioned there, if you have that intermediate non-double negative scenario, the thing is that at this time point you can basically submit data on not only HERG but also on the other ion channels, and specifically here also these best practices recommendations come true. So you should just run with the similar recommendations regarding, temperature and a voltage protocol, which is close to the heart, and also reporting of the different parameters that are monitored over the experiment. So basically all of these data help to identify the correct responses in the end.
Okay. And then Ali, you were at the end of the presentation talking about unattended runs. Can you comment on the time needed per run and the amount of drugs which could be screened using the system that you highlighted?
Sorry, I just have to unmute myself. Each experiment, I think, lasted around 20 minutes. The recordings were 10 plates in 6 hours. And in this particular example, there were 7 compounds that would run in duplicate, so effectively 14 compounds. Of course, I mean, you could run it in a way that you have a single compound on each well. You could run a cumulative concentration response curve. So the number of data points is kind of, it depends on how you set your experiment up.
Okay, and then kind of a follow-up to this regarding the time. How does maybe you can comment on the analysis of the data for such an experiment?
So the analysis is then automatically loaded into data control. The data is recorded in the acquisition software Patch Control 384, specifically made for the SyncroPatch 384. The data can then all be very easily and very quickly, with just a couple of clicks, loaded then into data control. And within a couple of minutes, you've got your concentration response curves for each of the compounds that you had running on that plate per plate.
Okay. And then another one for you, Ali, regarding incubation time of HERG blockers. Will it be more testing for more existing classical HERG blockers? Also a recommendation for blockers to use for basic experiments or where time could be important, like iPSC cardiomyocytes?
Yeah, so I mean, the minimum time really that we showed here is 5 minutes, probably actually 6 or 8 minutes is better. So for those kind of experiments, if you're using cardiomyocytes or something like that, and maybe the experiment doesn't last 35 minutes, you would probably take the approach of using a single concentration of compound per well so that you can reduce the time of the experiment. So get some five or so minutes of control recording, and then maybe 8, 9, 10 minutes in one single concentration of compound, and record then or calculate the concentration response curve across multiple wells.
Perfect. So once again, I'd like to thank Sonja and Ali for going through the presentations. I will make a transcribed copy of this presentation available on demand. More likely it would be available in full tomorrow morning. I will also make sure to add any additional contact information. So if you have any questions that you think of after watching once again, then we welcome you to get in touch with us at your next availability.